Welcome everyone to our session. It looks like people are slowly coming in. So I am Dr. Tricia Hugulay. I'm a pediatric and adolescent gynecologist in Denver, and I'll be serving as your moderator today. As you all come in, please introduce yourself in the chat. Let us know who you are, where you're practicing, and what you hope to learn today. In the chat is a really important sign-in link. Please don't forget to mark that as well. That helps you to get your CME credit. Looks like we have about 17 participants, and we're about 3 after, so I think we can go ahead and get started. Again, for those who were just joining, I am Dr. Tricia Hugulay. I'm a pediatric and adolescent gynecologist at University of Colorado and Children's Hospital, and work very closely in our combined hematology gynecology clinic. I will be serving as your moderator today for our session on continuing to discuss the recognition and care of women with bleeding disorders. So welcome. As you are joining, please look in the chat. You'll see there's a sign-in link. That's very important to mark your participation today, also to get your CME credit. And we please invite you. We know you're busy in your practice, but would love for you to come off video if you have the opportunity, either now or if you're able to engage in some questions during our Q&A session. And you can also in the chat share your name, your background, and where you are. We would love to hear from you and engage as much as possible. And with that, some sort of other sort of housekeeping items. Really important to note that everything, of course, is HIPAA compliant. So in the Q&A session, if you do have any questions to share, please again remember to keep all patient identifying information out of your question or out of the chat. There again is the sign-in link, and then there will also be an evaluation link at the end that we ask you to do both, again, in order to get your CME credit. Let's see. And so with that, I think we can advance our slide. Today, we're going to be talking about iron deficiency and its role in bleeding disorders. Also important for you to know that all of our speakers and presenters and those who have been engaged in developing this content today have also disclosed any potential relationships they have with industry. It is very important with Project ECHO for you to know that we are in compliance with ACCME standards for integrity and independence in accredited continuing education, and it requires anyone who is in a position to control the content to disclose if they have any relevant financial relationship. So you can take a moment here to see all of our planners, as well as any potential conflicts of interest. And now I have the pleasure of introducing today's presenter, Dr. Kristina Haley, who is an esteemed colleague. Dr. Kristina Haley is the director of the Hemostasis and Thrombosis Center at Oregon Health Sciences University. She also co-directs the OHSU Spots, Stots, and Clots Clinic, which is a combined hematology gynecology clinic for adolescent women with bleeding and clotting disorders. Dr. Haley spends time educating medical students, residents, and fellows, as well as our community health care providers on all things non-malignant hematology, with a particular emphasis on the care of women and girls with blood disorders. Dr. Haley's research includes projects aimed at characterizing the symptoms, the treatments, and the impacts of bleeding in women with bleeding disorders through a national data set, as well as improving the understanding of platelet disorders. So welcome, Dr. Haley.
Hopefully by the end of this, you'll be able to recognize signs and symptoms of iron deficiency, as well as in particular in patients with heavy menstrual bleeding and bleeding disorders, and then identify labs to use to screen for iron deficiency, and then recall how to interpret those labs. This is like one of my most favorite quotes of all time from the great pediatric hematologist Nancy Andrews, which is, "Iron lacks the glitter of gold and the sparkle of silver, but outshines both in biologic importance." And I think our patients and will tell us that maybe iron is the most important element in their lives as well. So there's a bunch of different proteins that contain iron in the body. We think mostly about hemoglobin, and that is our like best kind of outcome measure of when you're iron deficient. But this is a list, an incomplete list, but a lot of the proteins that iron is involved in, and it's all over the body. But it's really hard to know, how to measure somebody's xanthine oxidase effect in iron deficiency. So we really use hemoglobin as our best outcome measure. Another like Nancy Andrews quote, sorry, she was like a goddess of pediatric hematology, but human existence is inextricably linked to iron, and disturbances in its metabolism may have dire consequences. And the reason for that is that iron can exist in either its 2+ or 3+ state. So that allows it to act as a redox catalyst, and it can reversibly accept and donate electrons. And so that way it's participating in all of these different reactions in the body. And that's what I tell families or patients. I'm a pediatric hematologist, so lots of time talking to parents. But the reason why somebody might feel so kind of blah and kind of non-specifically so is that they're just like not having enough of this really important element to be able to do all of the enzymatic activities their body needs to do. Iron is really reactive because of this. So it can, as I said, donate and accept electrons. And so it always has to be chaperoned. So when it's circulating in the body, it's bound to transferrin, and that carries iron throughout the circulation, delivers iron to cell transferrin receptors so that it can be taken up into the cell. And then when it's stored in ferritin. And so this is our kind of best marker of long-term iron stores. And ferritin can hold up to 4,500 iron atoms. I just think about like how heavy that is. It's amazing. But when you need iron to make hemoglobin, to do the things in your cells, then iron will be mobilized from ferritin as needed. I like to think about where iron is in our body as our iron economy. And this is thinking about that our normal body iron content is around 3 to 4 grams. And it tends to be that males have more storage iron than females, whether this is biologically important or just representing that females are more often iron deficient, I'm not sure. And we only really take in or lose 1 to 2 milligrams of iron a day. So you take in 1 or 2 milligrams of iron through your diet, and then you lose some iron just in sloughing of cells like skin and mucosal cells. But you also like use some iron to make new myoglobin for your muscles, or you make more red cells, whatever it might be. And then for people with normal periods, you lose about 1 milligram of iron with your normal period. We have to take iron in from our diet, though. As I said, I'm a pediatric hematologist, and I am always amazed at how little, like, one food teenagers eat, and then two, just like how little iron they eat. So I always ask teenagers, like, what do you eat for breakfast? And they're like, nothing. I'm like, what do you eat for lunch? And they're like, chips. And I'm like, what do you eat for dinner? And they're like, I don't know, maybe a granola bar. And then I'm like, do you have a snack? Not really. I'm like, oh my God, you're starving. And there's 0 iron in your diet. These are the recommended daily dietary allowances depending upon age. I think it's always amazing to think about when you're pregnant or breastfeeding, like how much iron you actually need to be able to support both your body and the baby. But this is quite a bit of iron, and I think it's sometimes we can see iron deficiency develop due to menstrual losses, but it's often on the background of a chronic iron deficiency from inadequate dietary intake. Importantly, we get a lot of iron from heme iron because it's that's the iron in like meats, and we absorb that really well. And then the non-heme iron, like green leafy vegetable iron, is not absorbed quite as well. So looking again at people and menstrual losses, this was a study that looked at iron losses in women in Italy, and they had 84 people with normal periods and 21 people with heavy menstrual bleeding. And they assessed menstrual losses through a modified alkaline hematine method. So lots of like collecting pads and measuring and seeing how much blood was lost. And this table here highlights the different populations in these two groups. Sorry, I have to hide my chat so I can see the table better. And in these first two columns, we have the people with normal menses and the median and mean, and then the second two are the people with heavy menstrual bleeding. And we'll just note some like similarities, except for their hemoglobin and serum ferritin or SF. So definitely the people with heavy menstrual bleeding had lower hemoglobins as well as lower serum ferritins. And then this was the data looking at the mean iron losses in patients with heavy or normal menses as the first group, and then heavy menstrual bleeding as the second group. And people with heavy menstrual bleeding had 5 to 6 times higher losses of iron compared to women with normal menses. The mean daily loss of iron with heavy menstrual bleeding was 4.8 milligrams per cycle, with some people losing more than 1 milligram a day. So this is mean losses here, and you can just see how enormously different it is between heavy menstrual bleeding and normal menses. So really easy in your iron economy to end up with a deficit in your iron when you're having heavy menstrual bleeding. Iron is balanced by maintaining absorption for the most part. So absorption is regulated where loss is unregulated. Absorption is regulated by intestinal uptake, and it can be increased by up to 10 times in anemic states. But that means that you have to be anemic to increase your iron absorption. So those patients who are iron deficient without anemia often don't have increased iron uptake, and it can be really hard to increase their ferritin levels. But when somebody's anemic, they're like the best iron absorbers in the world, and you can really take advantage of that to get their levels back up. Absorption is responsive to iron status, erythropoietic demand, hypoxia, inflammation. And then on the opposite, loss is unregulated. You can't just like turn on a faucet and make yourself lose iron, but we lose it through sloughing of cells like skin and mucosa, bleeding, pregnancy. Things that can help your body absorb iron in addition to being iron deficient are, as I said, red meat, vitamin C, and fasting. So when we think about taking oral iron, vitamin C is helpful to absorb your oral iron dosing, but it's actually best absorbed on an empty stomach if you can do that. Things that make iron absorption worse are things like vegetable fibers, phytates, phosphates, teas and tannins, cow's milk, which maybe isn't as much of a problem in our adolescents and adults, but in a toddler, that's one of our main challenges. And then antacids is another one. So then if we think about the causes of iron deficiency, we can think about kind of not enough in, as I said, is the iron diet just not quite adequate? I think about our teenagers who, last year we saw them and they were 4'11" and now they're 5'4". And how did they grow? Well, they needed a bunch of iron to support that growth. We see a lot of iron deficiency and maybe endurance athletes, and that's probably owing to a really high iron demand by the body. And then also you lose a little bit of iron in running just from actually red cells breaking during like hitting the foot on the pavement. And then again, pregnancy is such a high iron demand that it's hard to keep up with that. We can also get iron deficient because of like bleeding too much. So back-to-back prolonged bleeding episodes, prolonged just like normal every month having prolonged bleeding episodes. And then other sources of bleeding in our patients with bleeding disorders, such as nosebleeds. If somebody's having 15-minute long nosebleeds 3 or 4 times a week, that can be quite a bit of blood loss as well. We can also see iron deficiency due to inadequate absorption. So people who've maybe had a history of an intestinal surgery where their duodenum was affected, that can affect iron absorption. As I said, other medications or food interacting with the iron absorption. And then a big one is celiac disease. The more rare is dysfunctional iron metabolism. So anemia of chronic disease can affect iron metabolism, and then just ongoing inflammation. There are some rare disorders of iron absorption that affect the transfer of iron, but those are pretty unusual. And the most common is that somebody's just not getting enough iron in to meet up with their demands. Iron deficiency, as you all, I'm sure, are aware, is incredibly common. This is really kind of old data now, but I think it's still quite reflective of the iron deficiency situation here. So this is NHANES data, the nutritional database from 1988 to 1994. And they demonstrated in this study that iron deficiency was really common and more common in those who were females in the adolescent and adult age than males in those age groups. And the iron deficiency anemia was also more common in females than in males. And so this prevalence data from the late 80s, early 90s correlated to 7.8 million women with iron deficiency, with 3.3 million being anemic. I was like, oh my goodness, the people are so tired and exhausted. Some other epidemiology data. So in 2019, the global anemia prevalence in women 15 to 49 years old was about 30%, equivalent to 500 million women worldwide, excuse me. And that doesn't mean it's all iron deficiency, but a large portion of it is. In the United States, the prevalence of anemia has increased from 7.8% in 2000 to 11.8% in 2019. Severe anemia affects 0.2%, moderate anemia 4.4%, and mild anemia 7.2%. Some additional kind of looks at epidemiology at a few different clinical settings. So there's a combined adolescent hematology clinic at UT Southwestern, and they looked at iron deficiency with or without anemia in their patients seen at their clinic, where a third of the patients had a bleeding disorder. And they found that a little over a third had iron deficiency anemia, a third had iron deficiency alone, and 2/3 had one or the others. And almost 20% had received a red cell transfusion, and almost 40% had received IV iron. I always think about those patients who have received red cell transfusions. As a hematologist, I give red cell transfusions all the time, but they are certainly not without risks, and certainly best to avoid if you can. In this group of patients with von Willebrand's disease, as well as some other bleeding disorders, they found that 22% of females with von Willebrand's disease had iron deficiency, 15% of females with other bleeding disorders had iron deficiency, compared with only 4% of males with von Willebrand's having iron deficiency. So it's definitely a problem, and most likely in these patients related to heavy menstrual bleeding. So let's talk about some labs. Think about our iron stores and our circulating iron, and as you get progressively iron deficient, you get poor erythropoiesis, and then that results in anemia. And these are the different labs that we can use, like serum ferritin, total iron binding capacity, your serum iron transferrin saturation. I tend to use the serum ferritin most commonly, and it's pretty, you have to have pretty significant iron deficiency anemia before we'll see our microcytic hypochromic anemia. The serum iron will typically be low in iron deficiency anemia, but it's highly impacted by the last 24 hours of iron intake. So if you just ate a big steak and then you got your labs done, then your serum iron will be normal and not reflect your overall iron status. This serum ferritin number is really controversial, and there are like entire days of conferences dedicated to what's the correct serum ferritin. So we'll come back to that here in a second, but just before we go here, I'm going to show you, this was a group of 114 adolescents with heavy menstrual bleeding, with 41% having an underlying bleeding disorder. Half of their patients had iron deficiency, a quarter were anemic, and only 23.6 had microcytosis. So if you're looking at a CBC and somebody has a normal hemoglobin and normal MCV, they still can be iron deficient. And I think that's something that can get missed, especially I know in a lot of pediatric clinics, especially people are using point of care machines or like finger pokes to get their CBCs, and we don't always get a ferritin. So as far as labs, I think absolutely order a CBC. Again, what you're trying to figure out here is there anemia? And then the ferritin is going to be your most sensitive marker. You can consider ordering a total iron binding capacity, transferrin saturation, and serum iron. These aren't going to be as sensitive, but sometimes this can be helpful, especially in patients with some inflammation or some other chronic illnesses, and just to get a better look at their whole iron panel. But let's come back to that controversy of ferritin. So, like I said, people, like if you ever want to like fire up some hematologists, just like ask them what their most defined ferritin is, and they'll have lots of strong opinions. I recently participated in a like a consensus guideline development about iron deficiency. And this topic, I think we spent like 6 hours talking about this. So lots of feelings about ferritins. In 2020, the World Health Organization kept their definitions as an iron deficiency equals a ferritin less than 15. There was a lot of rebuttal to that decision by the WHO, and generally people think that at 15, that's when your bone marrow is working really hard to make more hemoglobin, and that you're truly iron deficient. In 2021, there was a publication evaluating some of that NHANES data, and through that, they found that a ferritin of 25 was when you start, and less was when you started having iron deficient erythropoiesis. And so they recommended using a ferritin of 25 for non-pregnant women as the cutoff. And then there was a 2021 publication evaluating the hormone hepcidin, which inhibits iron absorption. So when hepcidin is elevated, you are theoretically then iron replenished because it's blocking further absorption. And they identified that a ferritin of 50 is the point at which the body begins to upregulate iron absorption. And so that would maybe correlate with iron deficiency. There's lots of different opinions about this. I tend to, in the teenagers, will say, oh, sorry, there was one other publication that just came out recently from the European Hematology. I don't remember what their acronym is. And they recommended a ferritin of 30. So I tend to say if your ferritin is 25 to 30 and you feel amazing, then you're probably not iron deficient. If your ferritin is less than 50 and you feel crummy, it's worth trying to see if your getting your ferritin over 50 will help you feel better, but certainly less than 25 and 30 is iron deficient. Symptoms can be really wide-ranging, and the most common is just feeling tired and maybe some headaches, and less commonly some of these other symptoms. And especially in our patients with heavy menstrual bleeding, if it's been more of a chronic problem, the symptoms will kind of be kind of long-standing fatigue, just generally not feeling well, as very different than somebody who presents with an acute episode of heavy menstrual bleeding where they might have symptoms of syncope or other symptoms. Pica or eating non-nutritive substances is not uncommon. My favorite question to ask patients is, what's your favorite kind of ice? Because then they'll be like, oh, I love that pellet ice. Or they'll be like, well, Starbucks is really good, but also I kind of prefer Dutch Brothers, which is like a coffee place here in Oregon. And so if they have a favorite ice, that is a high sign of iron deficiency. It's not always true, but it's not always correlative, but it's not uncommon. And then this is just kind of an interesting list of other non-nutritive substances that people have reported patients eating as a result of iron deficiency. I just I love pica stories. I think they're really fascinating that our bodies do these kind of amazing things. And so I like to ask people what they've been eating. My experience of patients with iron deficiency is that there's just this feeling of blahness, and that they're fatigued rather than tired. I often ask teenagers, if you slept all weekend, would you feel tired? Would you still feel tired? And if they do, then that's more concerning for fatigue. I think it's been reported in the literature and then also in clinic. I see worsening symptoms of baseline anxiety and depression and increasing challenges with attention. Exercise intolerances are really common symptoms. I think it's really challenging to sort out amongst all the blah-inducing things in the world, whether it's iron deficiency or just everything else. And so I think that is just an indication that it's reasonable to check for iron deficiency and treat if present. And at least you can cross it off the list of things that can make you feel bad. There's many, many studies evaluating quality of life, health-related quality of life, and iron deficiency anemia. One study reported here looked at health-related quality of life with the SF36 tool. And this was a group of patients, adult patients, with almost 50% having heavy menstrual bleeding as the cause of their iron deficiency, with pretty significant anemia of mean hemoglobin of 9.2 and mean ferritin of 3. And this was their different results on their health-related quality of life. And these are reported at their baseline, 1 month into treatment of iron deficiency, and then 3 months into treatment. And these all just correlate to different parameters on those scores. So physical functioning, role, emotional, physical, social functioning, mental health, et cetera, generally found that these symptoms all improved with treatment of iron deficiency. I get really stuck on this this information about iron deficiency and school impact. I see a lot of teenagers with iron deficiency, and this is again old NHANES data, but I think it just is so important to pay attention to. And they looked at patients with normal iron status, iron deficiency without anemia, and iron deficient with anemia, and looked at math, reading, and these other kind of markers of school performance, and found that math was significantly affected and lower scores for patients with iron deficiency without anemia. So really important for our teens and tweens going to school, and how iron deficiency can affect school. So now moving, on to treatment. I think that the kind of a really probably mainstay of treatment is correcting the cause. So I always tell patients, I can pour all the iron into you I want, but if you keep having heavy menstrual bleeding, I'm never going to get you caught up. So stopping or decreasing the bleeding is a really important part of treatment of iron deficiency. And I think that can be sometimes extra challenging for teenagers, but I think just continuing to use shared decision-making and trying to address kind of their goals of treatment is really important. Addressing dietary needs. I always at least try to give somebody a couple of options for iron-rich foods. I start listing them usually for patients and try to see which one they might eat. Oatmeal is sometimes one. Dry cereal has a good amount of iron. Potato skins, lentils. I just try to go through all of them. There's actually some pretty helpful iron-rich food information from the CDC, although they list sardines on there, which a teenager will never eat sardines. So just be aware. I also think that while heavy menstrual bleeding is typically the culprit, especially in our patients with bleeding disorders, they also have other bleeding symptoms. And so for me as a hematologist, maybe I want to make sure I don't just narrowly focus on their heavy menstrual bleeding, but also treat their nosebleeds or other bleeding. And then either oral or IV iron supplementation. For oral iron supplementation, there was this study that was published back in 2015 that got a lot of press and really changed how people dose iron. And there's a few caveats that are really important for this study. So this looked at dosing of iron in patients who were iron deficient but not anemic. And they were either given a higher dose iron, or a daily dose iron, or an every other day dose iron. And they looked at hepcidin levels and then how hepcidin levels correlated with the dosing of iron and then absorption of iron. And what they found is that when you take an iron dose, your hepcidin levels increase and stay up for about 24 hours. And so if you dose twice a day, then your second dose of the day will be blocked by the hepcidin that was released from your morning dose. And that maybe that hepcidin stays as long as the next day. And so every other day is is better absorbed than daily dosing. This has been reproduced in other studies as well, but the really important takeaway from this is that this was a group of patients without anemia. And remember, in patients with anemia, their iron absorption is increased by up to 10 times. And so in somebody with iron deficiency, sorry, it's my pager, sorry if you could hear that. In patients with iron deficiency with anemia, then you should continue with daily dosing. And even sometimes I'll do 2 tablets at the same time a day. But if somebody's iron deficient without anemia, then you could either do daily or every other day, whatever is easier for them. Sometimes that every other day dosing can decrease GI side effects, so it can be really helpful. Again, if somebody's iron deficient, I will do every other day, and then but if they're anemic, I'll consider daily and even 2 tablets 1 time a day. And as far as formulation, I'll say whatever the patient will take. There's gummy options, there's chewable options, there's liquid options, there's tablet options. And usually there's like lots of really strong feelings about iron tablets that people feel. And so I have a list of irons that people have told me they tolerate. And so I'll just be like, let's find one that looks good to you. On an empty stomach is best, but if taking with food, it is helpful to add a vitamin C, either tablet or just take with orange juice or orange or other vitamin C fruit at the same time, and then avoid taking at the same times as teas, coffees, and calcium. And what I forgot, because I'm a pediatrician, is that wines also contain tannins. And so if you're an adult doctor, don't take your iron with tannins as well, or with wine. For intravenous iron, the indications include unable to tolerate or take oral iron, inability to absorb oral iron, or difficulty keeping up with blood losses. So sometimes I'll see a patient who's maybe had heavy menstrual bleeding for the last, since menarche, they're 6 months in, and their hemoglobin's 8. And we're just now talking, it's their first visit. Okay, how are you going to get your periods to not be as heavy? And I know it's going to take a few cycles for their new combined pill to take effect. Well, I need to give them some more iron to help make sure they don't get into a crisis mode until their periods are better. And so in that case, I'm more often going to give upfront intravenous iron. Generally, IV iron is really well tolerated. There is a risk of allergic reaction, including anaphylaxis, but that is super rare. There's some other types of reaction. One is called a Fishbane reaction, which has flushing myalgias, a sensation of fullness in the throat, but it's not allergic, but it's really hard to differentiate between the two. And so either in both cases, you stop the infusion and respond to the reaction as necessary. Some people develop fevers, arthralgias, myalgias the day after iron. And then generally pre-medication is not needed, but it's recommended in patients with multiple drug allergies, history of asthma, or other inflammatory arthritis. And then it's recommended to use steroids or an H2 blocker rather than an H1 blocker. There's a bunch of different IV iron options. They're listed here. It tends to be, if you can get access to a single dose infusion iron rather than multiple doses, at least that'll go faster for a patient and have not to have as many visits. I don't know about you all, but our hospital is currently experiencing the IV fluid shortage. And so we're currently in an IV iron pause because a lot of these irons have to be diluted in saline. And so we're currently only allowed to give IV iron for those with severe anemia. But hopefully at some point we'll get IV fluids again, and then we can all go back to giving IV iron more liberally. The response to treatment, so for oral iron in 1 to 2 weeks after starting, you should see reticulocytes if somebody's anemic, especially. And then if they're anemic, their hemoglobin will increase by about 1 gram per deciliter in that 1 to 2 weeks. And then by 3 months of oral iron supplementation, the anemia should be corrected if your cause has been corrected. If you're still having heavy menstrual bleeding, you're going to have to continue the oral iron. And I tend to think about continuing oral iron for 3 months after the cause has been corrected so that we can really make sure that their iron stores are increased in addition to their anemia. For IV iron, I usually wait at least 4 to 6 weeks to check ferritin, because if you check it too soon, it'll be like a bajillion and then everybody has like a panic attack, but it's just reflecting your iron infusion. And then if somebody's not getting better, I just think about other ongoing blood losses or other causes that might be causing the iron deficiency than what I had assumed was going on. For results, a response again, study of adults who donated blood and were found to be iron deficient. They randomized these patients to receive either IV iron IV iron versus oral iron. And they included 178 individuals with a whole bunch of women compared to men. And they found significant improvement in fatigue, as shown here, as well as restless leg symptoms and sleep quality, and significant decrease in headaches, dyspnea, dizziness, and palpitations. So generally, if you treat iron, people feel better, or iron deficiency. This was another trial that looked at placebo-controlled randomized between either IV iron or placebo, and included women 18 years and older with a ferritin less than 50. And they included 90 women, and then they looked at fatigue. And they found there is actually no difference between fatigue scores at baseline. But this figures are for people with ferritins less than 15. And they found that fatigue scores improved and 63% of the iron therapy group, and it actually improved in 34% of the placebo group, which is kind of interesting, and maybe argues that actually just like asking the questions and kind of paying attention to this population is helpful. In my experience, individuals with heavy menstrual bleeding tend to have a chronic iron deficiency, and especially in the teenagers, this may be related to diet as well as their kind of every time they have a heavy episode of bleeding. And then they will have like an episode of acute blood loss. And so it's kind of this chronic iron deficiency and then an all of a sudden presentation. The MCV is often not decreased on their CBC. And so I just think it's not always helpful in predicting iron deficiency. And patients are often so used to being iron deficient that they don't report a lot of symptoms. I saw a patient recently who was like, I don't know, I just kind of feel like it's hard to climb the stairs. And she was like a 12-year-old, like totally, like somebody who should run up the stairs. And then got a CBC and her hemoglobin was 6. And I was like, well, that's why you can't go up the stairs. And they're just like, it was like not that big of a deal. And then I think earlier intervention in these patients with chronic heavy menstrual bleeding can really prevent the acute presentation requiring red cell transfusion. So I always think about like, if I'm treating their iron deficiency, that I'm giving them wiggle room for their next episode of heavy menstrual bleeding if we don't have it under control. If you've ever taken oral iron, it's kind of the worst. It generally sometimes can make you feel sick. It makes you feel constipated, and it's hard to remember. So I think in somebody who's having severe anemia, and especially with ongoing heavy menstrual bleeding, and even those patients who just are feeling gross for the last forever, if you can get IV iron, it's faster and easier. And then I think that sometimes demonstrating iron deficiency can really help somebody realize that they're losing a lot of blood and kind of motivate them to start treatment for their heavy menstrual bleeding. So in summary, iron deficiency is super common, even more common in patients with heavy menstrual bleeding. And as a reminder, heavy menstrual bleeding is a very common symptom in patients with bleeding disorders. Signs and symptoms of iron deficiency can include fatigue, headaches, restless legs, eating ice, dizziness, but sometimes not very many symptoms whatsoever. A CBC and a ferritin are the baseline that you should include in your evaluation. and low hemoglobin plus low ferritin equals iron deficiency, but be aware of what your lab, how it marks ferritin. Our lab for children says ferritin of 12 is normal, so just pay attention to what your lab cutoffs for, and consider treating if your ferritin's less than 50 and the patient, especially if the patient's feeling blah. Okay, I think that's all.
Thank you, Dr. Haley. That was a wonderful overview and with a lot of really important, relevant literature about how we should think about iron deficiency and manage it. And I will just add anecdotally, I so appreciate that you brought up the point about patients just sort of normalize the iron deficiency symptoms and don't necessarily report them. I had a 40-year-old patient in our clinic the other day, just newly diagnosed with a bleeding disorder and basically as we were going through the checklist of iron deficiency symptoms, I mean, her jaw literally dropped. She's like, how did I not know that all those things weren't normal and that my constant craving for ice and all these things, she had no idea. And it was just like almost a life-changing moment for her. So really important to ask the question. So thank you for that. There were a couple of questions in the chat. One, what are all the options for treatment of adolescents with heavy menstrual bleeding? Whew, that's a big topic in and of itself. Unfortunately, we're not directly covering today. I think we have a few minutes in the case session. We could maybe touch on it, but otherwise, definitely a topic for us to take back and develop. As I think in this particular 4-session series, we didn't necessarily address treatment specifically, although I know that Hemophilia Federation of America has a lot of wonderful resources on their website. And I also know the Foundation for Women and Girls with Blood Disorders has a lot too. So those are some other resources for you. And then there was a question, will there be a discussion of iron overload? Kristina, I don't know, that's a big topic in of itself. I don't know if you want to comment on that really quick before we do the post-session poll, or if that's
Sure.
too big to
Yeah.
tackle.
So, certainly we can see inherited iron overload, so the hemochromatosis disorders, and then like transfusional iron overload, which is uncommon. I will say real quick for transfusions, if somebody gets a red cell transfusion because of acute blood loss anemia, especially related to heavy periods, you still need to treat their chronic iron deficiency. That the blood that you give them just like replenishes kind of the iron that's going to keep their hemoglobin maintained. You still have to give them the iron to correct their deficiency to build back up their hemoglobin to a normal level. From a iron overload, the hemochromatosis, it's an interesting disease, and that there's not a great genotype phenotype correlation. So you can have the genes that make you have hemochromatosis, but not everybody with that develops iron overload. They're actually really common genes that are mutated in the general population, and not necessarily like not everybody has iron overload. If somebody has iron deficiency, you should treat their iron deficiency. And so you don't need to worry, like if somebody's ferritin is 2, that you're going to like give them too much iron and they're going to develop iron overload. But if somebody has a history or family history of iron overload, it's probably more important that you can check to make sure they correct it and then stop when their iron has corrected.
Great, thank you for that. With that, I think we'll go through the post-session poll again. So if I didn't mention before, be careful that you're sort of scrolling through these questions. But again, question 1, according to a 2014 study evaluating iron losses in menses, women with heavy menstrual bleed had approximately what amount times higher loss of iron compared to women with normal menses? Question 2, which of the following hinders intestinal iron absorption? Question 3, according to a 2013 review of patients with von Willebrand's disease, what percent of females with von Willebrand's disease had iron deficiency, while 4% of men were reported iron deficient with von Willebrand's? And then the 4th question, which of the following is not a very frequent symptom of iron deficiency anemia? And once you have your answers, you can submit, and we'll see how the group collectively answered. All right, and it looks like Still some variability on the first one, which is bare, a lot of iron deficiency, which is the following and hinders intestinal absorption. Dairy products, absolutely. Looking at the percent of patients with von Willebrand's with iron deficiency, 22%, and a little bit of most patients agreeing that syncope is not a frequent symptom of iron deficiency anemia. Thank you to everyone for joining us today and participating. Please don't forget to utilize this link to provide your evaluation. It's critical for a few reasons, so you can get your CME credit. Also, so we can really learn from you to help provide new and educational materials. And we really do take your feedback very closely and seriously to kind of help develop our content. And again, maybe something specific to really talking about the treatment for teens with heavy menstrual bleeding. So thank you for that suggestion. There's also a link here in the chat to register for our November session. So as we mentioned, this is a series of 4 sessions over the fall addressing various topics with regards to the care of women with bleeding disorders. And our last talk or sort of topic in this area in November is really geared around once you have that laboratory evaluation, once you've seen that patient, then how do you think about involving your hematologist and when to involve the hematologist and sort of the transition to that next level of care and evaluation. So we, again, thank you so much for your time, and you can use those links below to finish your evaluation. And thank you all again for your participation. Hope you have a wonderful week. Thanks again.